Greetings again, friends. We are going to touch on the ophthalmologic topic of strabismus here. And strabismus can be difficult to understand for two reasons. One, it's very heavy in physics, especially physics of lens, physics of optics. Number two, it also is difficult in the physical exam techniques that you're going to use, not necessarily doing the physical exam, but knowing what you're looking for. And furthermore, there is no such thing as just strabismus. We talk about strabismus because there are some similarities between all the different types of strabismus. However, a diagnosis of strabismus is not going to be helpful for an ophthalmologist. If you're a pediatrician or an internist, general practitioner, and you just write down that the patient has strabismus, that doesn't necessarily help them. And so that's why we're going to go over some of the naming conventions so we'll be able to diagnose definitively exactly which kind of strabismus the patient has. So we'll do an introduction with some introductory factors, some rudimentary anatomy that's going to be concerned when we talk about the eyes and their movement, extraocular muscles, some of the naming conventions. So when you see that the patient has a non-paretic esophoria, you know what that means, as opposed to a paretic comitant exotropia. Then we'll talk about the esophorias and esotropias, the exophorias and exotropias, acute strabismus, some of the complications, long-term complications of strabismus, especially if it's untreated, and then we'll recap everything and talk about the most essential points. So what I do want you to know right away is that strabismus, by definition, is when the eyes, the orbits, are not aligned properly. And so you can see in this child who is supposed to be gazing at the camera, this eye, the left eye here, is turned inward. It's not appropriately in communication. It's not appropriately aligned with the right eye. So strabismus is a misalignment of the eyes that affects the ability to attain stereopsis, and stereopsis is forming an appropriate image relative to what's around you. And this affects approximately 4% of the population in the United States. Typically, it's diagnosed by age 4. Remember that at 6 months of age, babies should have their first ocular exam, their first exam with an optometrist. Symptoms include diplopia. You can imagine that if one eye is seeing one thing and another eye is seeing something else, you're going to perceive two images. Eye strain, headache, blurry vision, poor depth perception, difficulty with reading or learning how to read, especially in these younger patients. And in severe cases, the misalignment may be obvious. Causes of strabismus include, but are not limited to, refractive errors. So that would be problems in one or both of the lenses that result in images that are not focused properly on the retina. Orbital size discrepancy, hyper or hypotelorism, which can be a feature seen in a lot of sequences, congenital sequences. And then, of course, issues of the extraocular muscles. So, for instance, if any of the extraocular muscles are weak, or if they're inserted improperly, or if the extraocular muscles are receiving an abnormal tonic innervation, be it too much or too little, that can cause a misalignment of the eyes as well. Risk factors for strabismus, for the development of strabismus, include nearsightedness or farsightedness, and that would just be your refractive errors. A family history of strabismus, neuromuscular disorders, they can affect the extraocular muscles, developmental disorders including Down syndrome, cataracts, traumatic brain injury, tumor of the brain or of the eye, a history of CNS infection, drugs or toxins, especially lead intoxication, certain systemic conditions, and Graves' disease. I tried to put these up on the top, the more common, and going down to the less common causes of strabismus, but I don't know if this is perfect. So remember, the muscles that control your eye, you have 6 of them. You have 4 recti muscle and 2 oblique muscles. So your lateral, medial, superior, and inferior rectus muscles all move your eyes in the direction that the muscle is named. So your lateral rectus moves your eye laterally, your medial rectus moves your eye medially, your superior rectus moves your eye superiorly, or it elevates it. Your inferior rectus depresses your eye. In addition, the superior rectus and inferior rectus do have a role in turning the eye medially, but the medial rectus is really what is responsible for turning the eye medially. The inferior oblique and superior oblique are small muscles that also play a role, sort of a secondary role, and the inferior oblique elevates the eye. So unlike the superior rectus, where that elevates the eye, and the inferior rectus, where that depresses the eye, the inferior oblique elevates the eye, and the superior oblique depresses the eye. And both of these muscles also can turn the eye laterally. As far as innervation, what you should remember is the 2 muscles that are not innervated by the oculomotor nerve. So the muscles that are not innervated by the oculomotor nerve are the lateral rectus. Remember what the lateral rectus does? It moves the eye laterally. And when you're moving anything laterally or away from the midline, you're abducting. And so the lateral rectus is controlled by cranial nerve 6, the abducens nerve. It abducts the eye away from the midline. The superior oblique is innervated by the trochlear nerve, and it gets that name because, as you can see here, it sits on kind of a trochlea. So here's your superior oblique, wraps around this trochlea, and then inserts on the eye. And so that's where we get the name trochlear nerve. But the rest of them, the rest of the recti muscle besides lateral and the inferior oblique, are all innervated by the oculomotor nerve. So these are the cardinal eye positions. So you can think of it like Brady Bunch, sort of. So you look straight ahead. You shouldn't be using any extraocular muscles. If you're looking up, you're going to be using your superior rectus plus your inferior oblique. If you're looking down, you're going to be using your inferior rectus plus your superior oblique. If you're looking to the right, you're going to use your right lateral rectus and your left medial rectus. And if you're looking to the left, you're going to be using your right medial rectus and your left lateral rectus. So strabismus is a condition where the eyes, just at rest, are not in an aligned position. This would be an aligned position right here. With strabismus, we don't have that. So you can see in this child, the left eye is turned in medially. And in this gentleman, the left eye is turned out laterally. So normally, your eyes, when they fixate on something, an object, on a face, they can fixate on to the same point. If you have an eye that is not in alignment, then you won't be able to fixate on the same point. So for instance, this child, his eyes are moved inward, his left eye is moved inward, and so because that left eye is moved inward, that eye is actually going to focus too far to the patient's right. Okay. And this man, his left eye is focused too far outward, too far laterally. And so when he looks, when he's trying to focus on this green dot or on the object, while the right eye works, the left eye is going to be focused out too far away from the midline. And so the point where the eyes converge is actually going to be further away from the object. So this causes that blurriness and the double vision that these patients run into. And it's all because the eyes are out of alignment, and there are various reasons that the eyes can be out of alignment. Like I said, refractive errors, orbital size discrepancy, hyper or hypotelorism, and issues regarding the extraocular muscles and their strength or lack of strength. So let's go over some naming conventions. First, what's atropia versus aphoria? So you hear the words esotropia, exophoria, hypophoria. What are those words? What does tropia and phoria mean? Atropia is where binocular vision, normal vision, cannot be obtained. In these patients, the symptoms of strabismus, the symptoms of the double vision, the blurry vision, they're persistent because they cannot obtain binocular vision. And this is also known as a manifest deviation. Aphoria, on the other hand, is where the binocular gaze can be obtained when both eyes are open and fixating, but when the strabismus eye is covered, it deviates. So, for instance, this patient here. So he looks normal, right? But if you were to cover, if he had aphoria, you would cover the left eye, and if the left eye had an exophoria, so meaning it goes away from midline, it goes outward. Once you uncover the eye, you're going to see that eye moving back into the fixed position, so it would be moving back in. So with phorias, when you cover the eye, it moves into the strabismic position, into the deviated position. And this is called a latent deviation. In these patients, usually their symptoms come on when the eye is tired. We're also concerned about direction. Horizontal and vertical are going to be what we talk about here. There's also torsional direction, which is rotating of the eye. That's beyond the scope of this lecture. So ESO refers to an abnormal deviation of the eye towards the midline. So this child has an esophoria, or an esotropia if it's constantly in this position. Exo refers to an abnormal deviation of the eye away from the midline. And so that's this man here. And in vertical, you can have hypo if it's deviated too far down, or hyper if it's deviated too far up. There are various causes of strabismus. The most important cause you need to ask yourself, is it due to paralysis of an extraocular muscle? So for instance, a CN6 palsy. If it is due to paralysis of an extraocular muscle, it's called a paretic strabismus. And so we know it's due to a paralysis. And if it's a non-paretic strabismus, then it's not due to paralysis of an extraocular muscle. And then the pattern. So is the deviation the same magnitude regardless of the gaze position, or does the degree of deviation vary with gaze position? So if you know this, you're pretty much good for any ophthalmology residency level rotation as far as understanding strabismus. Eye doctors, optometrists, ophthalmologists will go even more in depth in naming the exact strabismus that the patient has, but this covers the basics. So when you do a physical exam in a patient with strabismus, and a physical exam, full physical exam is always desirable. Examining the eyes and their movement is of paramount importance because that's going to help you diagnose the exact type of strabismus, whether or not it's atropia or aphoria, if it's eso or exo or hypo or hyper. So first thing we want to do is observe the cardinal eye motions. And the cardinal eye motions are just like we saw back here. These are your cardinal eye motions: looking up, looking down, looking left, looking right, looking straight ahead, looking up into the left, up into the right, down into the left, down into the right. So you can do that by just doing your cross and your box and having the patient look in all cardinal directions, making sure that those eyes are moving with each other and at the same degree. The next test you do is the cover-uncover test. With the cover-uncover test, what you're doing is, and this is to reveal a tropia, a manifest deviation, you're going to have the patient fixate on a center object, and you're going to do this multiple times. You'll have the patient fixate on a center object that's near, usually your nose, and then you'll do this test again while they're fixating on a center object, maybe across the room. So you cover one eye, and you're observing the opposite eye. And so if you cover the left eye, and the right eye is moving, then that's considered abnormal. If the eye moves outward, then that's considered an esotropia. Well, I thought outward is exo. What's happening here is that the eye is moving into an appropriate position for fixating. And so if the eye is too far inward to begin with, it's going to move laterally. It's going to move to the outside. It'll have an outward deviation to move into an appropriate place for fixation. So that eye was already too far in to begin with. So even though it's moving laterally, it was an esotropia to begin with, and so that's an esotropia. If it's moving in towards the midline, then the eye was too far out to begin with, and it's moving inward to an appropriate position. So that's an exotropia. And after you uncover the opposite eye, that other eye, will go into its original esotropic or exotropic position. So that's a manifest deviation. This is the cover-uncover test, and that will tell you if the patient has atropia or not. Patient may not have atropia. They may have aphoria. The aphoria is diagnosed by the cross-cover test. So what you're doing with the cross-cover test is you're having the patient look at your nose or look at something across the room, and you're alternating cover quickly from the right to the left, from the left to the right, and you're covering each eye. And what you're doing here is you're breaking the eye's ability to fuse the image into one, which they should normally be able to do. The eye with aphoria will be seen moving back into a normal position after being uncovered. So here, with the cross-cover test, we're looking at the eye after we uncover it, whereas with the cover-uncover test, we're looking at the non-covered eye. With the cross-cover test, you cover the right eye, then you move over to cover the left eye, and you're looking at what the left eye does. If the left eye is moving back, if the right eye is moving back into the normal position after being uncovered, and it's moving back into its deviated position, which is outward, then that's going to reveal an exophoria. And if it's moving inward, then that's going to reveal an esophoria. Okay, so here's a picture. So this maybe will help solidify this in your mind. So this is how the patient looks. And this patient clearly, you would think, has a right esotropia, because they've got this deviation, and you can see it, and they've got it without even having to test anything. But you can physically diagnose it by covering their other eye, and you note that this eye, this right esotropic eye, has moved into a normal fixating position. And when you remove this cover, this right eye is going to move back into this original esotropic position. So this is the cover-uncover test. The cross-cover test, on the other hand, is what we're looking at is the eye that's underneath the cover right after we uncover it. So the eyes look normal to begin with. We cover up the left eye, and the left eye has now moved into an esotropic position. Once we uncover the left eye and cover the right eye, we should be able to note this left eye moving from an esotropic position into a normal locked-on position. And so this would be then diagnosed as a left esophoria. And it works the same way for everything. With exo and hypo, you do the same kind of test. Okay, so let's talk about esophoria and esotropia just as a diagnosis. Esophoria and esotropias are seen more commonly in young people. There are two types. You can have a convergence excess or a divergence weakness. So think about it. When you converge, when your eyes converge to look at a near object, that's what's happening to your eyes. When your eyes look at a near object, the eyes converge. If you have an excess of convergence in one eye, that's going to cause esophoria when you're focusing on a near object. So let's say my left eye converges, but my right eye converges excessively. When I'm focusing on a near object, I'm going to have a right esophoria because my right eye is converged a lot further in than my left eye. So this is the most common congenital type, and often this is associated with farsightedness. Now, another way you can get esophoria or esotropia is by looking at a distant object. So when you're looking at distant objects, your eyes should more diverge. And let's say that the muscles responsible for divergence, which would be your lateral rectus muscles, are stronger on one side than on the other. When you go to diverge, one eye is going to be weaker and the other eye is going to be normal because you have a divergence weakness here. And so if you have a divergence weakness in your left eye, your eye is going to stay converged or relatively converged. And so you'll have a left esophoria because your right eye has diverged and your left eye hasn't diverged enough because you have a divergence weakness. So either convergence excess or divergence weakness. Those can both cause esophoria or esotropia. And then there's nonspecific causative types that you don't need to be worried about. So for treatment here, and this pretty much goes for everybody, the patient is referred to an optometrist for correction and to an I can't say this right now. Ophthalmologist, and that is to correct any refractory abnormalities which tend to coexist, and to plan the patient for surgical management, as most patients are managed surgically. They just monkey around with some of the extraocular muscles, reposition them. You don't need to know any of that. But typically when this management is done, surgical management is optimal between 6 months and 2 years of age. With exophoria and exotropia, this is more common in older people. If it begins with a child, usually it's after 2 years. Exophoria is common among older adults with presbyacusis, and there's a reason for this. With presbyacusis, it becomes difficult to see things close up. So eventually they stop using those convergence muscles, and because they stop using those convergence muscles, the convergence muscles get weak, and convergence weakness is a way you can get exophoria. So now think again here on the other hand. So convergence muscles, those are your medial rectus muscles. If you have a convergence weakness in one eye relative to another, then that eye is going to be pulled more off to the side. It's going to be abducted more. And so exophoria, in that case, will be more pronounced when focusing on a near object. One eye will be able to converge appropriately, the other eye will not, that you have your convergence weakness in. And so you'll note that exotropia in that eye. Divergence excess is where the exophoria or exotropia is more pronounced when focusing on a distant object. So if you have a muscle, a lateral rectus muscle that's too strong, getting too much tonic innervation, when you diverge your eyes to look at a distant object, one of those eyes, the one that's getting too much innervation, is going to diverge too much, and that's going to cause an exophoria or exotropia. And the treatment here is pretty much the same. The patient is referred to an optometrist or I can't say that word today. Ophthalmologist, one of those days. And any refractory abnormalities should be treated with glasses or bifocals. There's orthopic exercise that can be done with esophoria, esotropia, exophoria, exotropia, and surgery can be done particularly in children because there's something that we're really concerned about that any kind of strabismus can cause, and it's a permanent damage, and we want to prevent that from happening. And so let's see if we talk about it on the next slide. Oh, no, not quite. Okay, so one other thing that has to do with strabismus is an acute strabismus. So most strabismus develop before age 5, before kindergarten, before a kid goes off to school. If you develop strabismus and you're older than 5 years of age, especially if it develops acutely, that is suspicious for a neurologic secondary cause. And so some things that can cause that are CNS neoplasms, head trauma, multiple sclerosis, Chiari malformation, ophthalmoplegic migraine, meningitis and encephalitis, and neurovascular disease. So strabismus almost always develops during early childhood. If it develops during later childhood or into adult years acutely, you should be thinking of a secondary cause. So the complications of strabismus include untreated, if it can interfere with interpersonal relationship, as it's difficult to maintain perceived eye contact. So when somebody's looking at you, they expect you to make eye contact, and if one eye is looking off to the other side, it's not the person with strabismus's fault, but they may be perceived as not making eye contact, and that can hamper social relationships. There's also an increased risk of developing mental health disorders. The link to that is not quite known, but it has been demonstrated in the literature. And it's also associated with employment problems, and that's due to the fact that strabismus interferes with depth perception. We require 2 working eyes, binocular vision, to make full use of our depth perception. So airline pilots, athletes, mechanics, any job that requires good depth perception, watchmakers, so on and so forth. And the most problematic complication of strabismus is the permanent development of amblyopia. So with amblyopia, what happens is the brain, the children have a very plastic, very responsive brain that can wire itself in all sorts of different ways. And if one eye is not working appropriately, the brain is going to say, well, forget about that. I'm just going to take my imaging from the left eye or from the right eye. And so the left eye or the right eye, whichever eye has the strabismus, is not going to set up its neuronal connections to the primary visual cortex. And that is a problem because then that eye essentially becomes blind. And so that is amblyopia. We want to treat strabismus so that we don't get amblyopia. And strabismus is one of the leading causes of amblyopia. You also see amblyopia because of refractory problems or amblyopia because of untreated cataracts. There's one more thing I want you to see here, and that is pseudostrabismus. And pseudostrabismus is something that looks like strabismus, but it is not. It's a false appearance of strabismus due to factors that affect the way the eye appears or to something that displaces the position of the eyeball. So most commonly, this is encountered as pseudoesotropia, frequently in infants and in Asian children. And in infants, the epicanthal fold has not finished developing. And in Asians, the epicanthal fold is a little bit different looking, and so that may make it look to the clinician like the patient has an esotropia, when indeed they don't. So, for instance, in this baby, the epicanthal folds are not finished forming, and so you can see there's no white sclera on this side of the eye, on the left eye, but there is on the right eye, and so you might think this is a mild esotropia. But it's not, because it's an epicanthal fold that's covering up the rest of the sclera. And so this is, if you see strabismus in a really, really young baby, make sure that you're ruling out pseudostrabismus. And ptosis can cause a pseudohypertropia. So here's a patient who has a mild ptosis, and you can see his eyelid is covering up the top part of his eye, and so that's going to make it look like the eyeball is higher up in relation to the other eyeball, but it's not. It's just being covered more. So you can see how this may appear to be like a pseudo-hypertropia or a hypertropia, but it's not. So ptosis can be a cause of pseudostrabismus too. So the moral of this slide is to make sure that you're taking into consideration anatomic factors that can affect the appearance of the eye or displace the eyeball. So recap, misalignment of the eye affecting the ability to obtain stereopsis, that is strabismus. There are many possible causes and many risk factors. Remember the nomenclature, esotropia, phoria, and what they mean. Some strabismus is blatantly obvious on appearance, but an eye exam can uncover more discrete cases. So the cardinal direction, those will uncover eye movement disorders. The cover-uncover test will diagnose atropia. The cross-cover test will diagnose aphoria. And strabismus developing acutely after age 5 should be worked up for secondary neurologic causes because strabismus usually does not develop after that point without some kind of secondary cause, and usually it's neurologic. Patients diagnosed with strabismus should be worked up for refractive errors as well as any other eye pathologies, and they should be managed by an optometrist and an ophthalmologist. And surgery is very useful for some patients, especially younger patients, but not all patients necessarily need surgery. There are other ways that they can be treated. And the major complication of strabismus is amblyopia.